So the theme for the celebration is "Are your kidneys okay?" Are your kidneys okay? It was the theme for this year's World Kidneys Day celebration. There's been several activities in the course of the month. And we as PSG, especially with children in mind, we want to ask you whether your children's kidneys are okay, your patients' kidneys are okay. So this is an advocacy for us all. You realize that even though it's an Ashanti regional PSG meeting, we've opened it up for the entire country because we believe that it's a matter of necessity that we keep our children's kidneys very healthy. So since we are in Ashanti region, of course, we have to hear from the owner of the boss himself of Ashanti Regional PSG. And so we have our chairman, who is my direct boss, Dr. Eugene Mate, a pediatric intensivist. And then he's very passionate. If you're an intensivist, the kidney is one of your priorities, not only the lungs, because a failing kidney is an intensivist nightmare. So we invite Dr. Mate to give us an opening speech by the president. Thank you.
Thank you very much. Okay, my work here will be in twofold. MC, permit me, I didn't ask permission, but I'm going to do it anyway. So first of all, I would like to welcome all of us. I think this is our first official meeting as Ashanti region for the year 2025. And I would like to, on behalf of the executives of PSG Ashanti, welcome all of us and wish you once again a happy new year. And I hope the year is going well. Okay, so my second appreciation goes to renal team of Confanochi for really pushing renal month. They've been very visible, and I'm even scared to eat because you pass here and they're telling you you can't eat this. Yeah, so we hope to carry your work far beyond the month of March and even beyond 2025. So once again, kudos to Nanekia and team, the LOC, for putting all of this together. And then also, I'm very grateful to all the speakers that we reached out to who accepted this opportunity to educate us on renal health. The second bit of my work here, I would like to once again remind us of what PSG is about. Okay, and I would like to throw a few questions to us. How many of us are doctors, including those online? How many of us are nurses? How many of us belong to the allied health professional group? Any teachers online? Or are you simply someone who just loves and cares about children? Okay, and that is all the qualification you need to be part of the Pediatric Society of Ghana. Okay, and then if you also seek to engage in discussions, share insights, and to learn from others, then this is the right platform for you if you want to improve your health knowledge in management of children. And then I'd also like to know, okay, do you get frustrated on a daily basis? You identify problems and you are looking for avenues to channel all that frustration and complaints. I would say PSG is one group you can look at to try and facilitate that. Okay. And then last but not the least, are you hoping to make societal change, collaborate with others to see this come true? Okay, and that is why Pediatric Society of Ghana exists. Okay, we are the beacon of hope for every child in Ghana, right from the preterm at neonatal intensive care unit to the teenager who is chasing birth lizards on the street. All of us, okay, are seeking to make sure that these category of Ghanaians or citizens in our country receive the best of care. And I must say we are an NGO, so we really rely on the support of all of us. No one is being paid, so we work together with you to make sure that we are able to push the agenda of PSG. Okay, so if you're not yet a registered member, at the end of the program today, I'm going to pester you to register and be part of PSG. Not just you can find PSG wherever you are. Greater Accra regional branches available. I know Koforidua, the Bono region, Northern, Volta. So PSG is closer to you than you think if you haven't heard of it yet. So once again, I would like to thank all of you for making it for today's meeting, and I would like to hand over to the MC to take over. Enjoy the program.
So much, Dr. Marty. All right, thank you so much, Dr. Marty. And then, yes, he said a lot. PSG is open to all. So everybody and anyone is invited to join PSG. So long as you have the advocacy of children at heart, that is all we need. That is the only criteria. Whether you're a parent, you're a teacher, you're a doctor, you're a nurse, any level or any kind of work you're involved in, it doesn't really matter. So while still at it, all this has been put together, like Dr. Martin said, by the nephrology team of Pediatric Society of Ghana. And then we are blessed to have the chairperson of the team, who is heading the local organizing committee. And my only boss, and she has done so much in the past month to help put this together, to create awareness. And we've invited secondary school children and then educated them on kidney health, together with the adult team. And so she's been very involved. And then we have her here this afternoon to give us an address, a short address. And so let's invite Dr. Nana Ekia.
Thank you very much, Michael. Good afternoon to us all, those online, those in-house, and welcome to our first Pediatric Society of Ghana meeting, Ashanti region. I'm very delighted to be here today. And as we gather here today for this important meeting, we as healthcare professionals, doctors, physician assistants, our nurses, dietitians, remember renal is a teamwork. We can't do it alone. So we need everybody to be with us. And once we are united by a common purpose, that's to improve the lives of children with kidney disease and to offer them hope for a brighter and healthier future. Now, I remember when I was given the mandate last year, 15th May, when I was elected to chair, and I was like, I have giants in front of me, I have seniors. And I remember Genevieve saying, no, but the seniors are so busy and they really want the juniors to take over. Okay, can I really take this mandate and do it well? And I'm so glad that together with my secretary, Dr. Anastasia Prosovora, I've enjoyed the journey so far. And I'd like to thank all of you, those online, those in-house, for making this a success so far. I think you all deserve an applause. Thank you so much for pushing me this way. And as we work together to improve the care of children with kidney disease, we must all recognize that no one person or discipline can do it. Pediatric renal care demands a multidisciplinary approach, one that brings together the nephrologists, the intensivists, the nurses, physician assistants, social workers, the psychologists, even the family. And with collaboration, we'll be able to do this, even with our churches. Because I remember when we started posting these things this much, people keep asking, are you sure children also suffer from kidney disease? So it means the work out there is a lot. We still need to educate. People always think it has to do with the adults, but at least this month of March, we've made a lot of people aware. Not only those who didn't go to school, even those who went to school, the literate, they still can't believe that children get kidney diseases. And I would also like to thank PSG Nick for bringing this idea of subspecialty groups, because trust you me, I think I would have been hiding in my corner somewhere. And also for PSG Ashanti Eugene for letting us host this first meeting. And to all the backdoor loops of Henley, Sister Esther, and then Yako, Anas, Esinam, Harina Francis, Kwame Akoi, and Apokia Juliet. I couldn't have done this without you guys. And today we have the privilege of being bathed with knowledge from our giants again, Prof. Samson Inchi, Dr. Masafo. So all we'll say is ride along with us through this task of capillaries. You're in the glomerulus with us. And today, by the end of the journey, we hope you all become better functioning units of the kidney, and we can call you all nephrons. Thank you so much.
Mentioning partners, you didn't mention infectious disease. Meanwhile, your MC is an infectious disease fellow. You will see. When you get pyelonephritis and you don't know what antibiotics. Anyway, so we'll continue with the meeting. And then, yes, so we are at a very important aspect of the meeting. And you know, for every program of this magnitude, we need someone to sit in chair. And I am so tempted to introduce this person because he is one of my mentors, and a great one as such. I admire him so much. But unfortunately, that honor is not mine. So to introduce and then welcome our chairperson, I'll invite one of our very hardworking doctors to do me the honors or do us the honors. So Dr. Jacinta Pashi will help introduce our chairperson for today.
Good afternoon, ladies and gentlemen, and distinguished guests and esteemed colleagues. First off, I'd like to thank Dr. Ajimanapia and Dr. Mensa for the opportunities and honor. Our chairman is a senior specialist, pediatric intensivist, and adjunct lecturer at the Konfanochi Teaching Hospital and School of Medicine and Dentistry at the Kwame Nkrumah University of Science and Technology. He earned his MPhil in 2015 from the University of Cape Town, South Africa. He was the team lead of the COVID-19 case management at the World Health Organization Regional Office for Africa and a consultant at the clinical management team at the WHO headquarters, Geneva. Also, a board member of the World Federation of Pediatric Intensive and Critical Care Societies, the International Pediatric Association, an executive member of the Africa Sepsis Alliance, and the former president of the Pediatric Society of Ghana. Ultimately, this noble sir is a lovely husband and a father to many. Ladies and gentlemen, with a warm welcome, your chairman, Dr. Adebi Apia.
Okay, thank you, Dr. Jacinta. And then for the generous words that you've given me, very appreciative of that. Thank you all for joining us this afternoon. First, I'm going to ask and to crave your support to pull us through this meeting. Hopefully, this is going to be a very useful one for all of us. So I will ask you to indulge me, the audience, the speakers, and then the esteemed members of Pediatric Society. Just a little bit of what I know about kidney diseases right now in Ghana. What is in the literature is that the prevalence is about 13.3%. But last week or 2 weeks ago, I was listening to a discussion, and out of the discussion, I got to know that prevalence actually is now about 17%. So almost 1 in 5 people in Ghana lives or have a kidney disease, and that's scary. So it's moved from a simple classroom, clinical practice, and now it's more of, to me, it's a public health emergency. You've heard a lot about the outcry the past few years. Patients living with kidney diseases advocating, there are advocates who will advocating, pushing government to do its part. Children are not different from the adults advocating. And fortunately, the benefits of that actually rain down. I also know that the previous government established a special program that was paying for the kidney renal replacement therapy. Under the current government, I'm deeply aware that it's not only the way of financing it will change, go in a different direction. But in the end, financing is very important. Our focus is not only on financing, but again, preventing it. And I'm sure the NACRIA and team will be happy to see few patients with kidney disease, in spite of the fact that their l'agent they'll have less leisure. But anyway, the most important thing we've gathered here is to discuss the way forward for children with kidney diseases or kidney problems. I don't think I can go on and on and on. I'm not an expert in this area, even though I see patients today. 2 out of 3 patients I have seen this morning, they've had kidney issues, and that is the extent of the problem. I will be listening rapidly to the speakers because I need to hear what they have. They have a lot of new information, a lot of things to share with us. And on that note, I'll hand over to the MC to take over the steering of the affairs. And then at the end of it all, I'll see you again. Thank you.
Thank you so much, Dr. Adebia. Yes, please take your seat on the high table for us. Thank you. Yes, so we'll continue with our program after that very lovely acceptance speech from our chairperson for today's event. And like I said, he is a man of many talents. He's very well read, and we are happy to have you, Chair. So to continue with the meeting, please, those online, I hope you are still with us. We'll be starting our lecture session very soon. And I can see our first presenter has started sharing her slides. So let's get ready and then prepared for the series of lectures we are about to receive. So to give us the first lecture this afternoon. All right, so our first presenter is a nephrologist. She is a fellow in both Ghana College of Physicians, the Surgeons, and the West African College of Physicians. And she is a very renowned pediatric nephrologist. But she nearly fooled me there. But ID was stronger. And then this afternoon, she give us a lecture on how kidney diseases present in children, which is very key, especially for us all around in the district. You need to pick up the early signs and then the early warning shots so that you can know when to intervene and then how to refer them as soon as possible. But before she comes in, I want us to quickly acknowledge the presence of a very important guest in our midst for those in-house. And we are blessed to have a very big woman in our midst today. I think she may even shortly join us on the high table before she takes leave. She told me she wants to do so. Yes, so we have DCNO, DCNO Mensa, who is in charge of this structure where we are holding the conference. So if she decided not to give the place to us, we would have been found wanting. So this year, that we are so grateful for your presence, that you didn't only give the place to us, but you actually came to see what is going on. And then for that, we are very grateful. Yes. So we thank you for joining us. And then at any time you want to take leave, you are permitted to. So Dr. Nimasafo, please, I will shortly be handing over the mic to you so that we have our first presentation on how kidney diseases present in children. Thank you very much.
Thank you, Eko, and good afternoon to you all. Sorry I couldn't join in person. The water shortage is a big problem for me, for the children who are on dialysis, and they are coming in acutely, so I have to be out and here to wait for one in an ambulance coming. So sorry for that. Okay. I know Professor Entry was supposed to give the first presentation, but as always, I'll stand in for him. Eko, when he comes, tell him this is the last time I'm doing it. Okay.
Yes, boss, we will tell him.
All right. So this afternoon, I'll take you through briefly. I have very few slides on how kidney diseases present in children. So by way of my outline, I'll give you an introduction, a general overview, a few specific symptoms that are directly geared to the kidney, and then a conclusion. Okay. So I'm sure everybody in the room, whether you're a clinician or a nurse or a physician assistant, I'm sure by now, if you've practiced for at least a year or two, you would know that the clinical presentation of kidney diseases, they are so non-specific. Even when it comes to advanced CKD, you may have a child who comes in with fever, headache, anemia, and they are all pointers to kidney diseases. And even when it comes to neonates, they even come with CNS symptoms or GI symptoms. And all your focus will be on the CNS or the GI, but really it may just be a sign of a kidney disease. So febrile seizures in neonates, vomiting, diarrhea, they may all be pointers to kidney diseases. So as anybody who practices in the clinical setting, you need a high index of suspicion and a sound knowledge of clues, which may lead you to a clinical diagnosis. And then you'll be able to detect early and then manage effectively. So this is a slide I borrowed from Professor Samson Entry. He says anything can be a sign of genitourinary disorder. And truly it is so. Anytime I present this slide, I always say that, in fact, there are two main organs in the body that are important, the kidney and the heart. All the others are supporting stuff. We'll debate on that later, not today. But the take-home message on this slide is the kidney is very, very important. If you look at the organs from the brain, your mental state, somebody can come in so confused, so delirious, and you go and check your labs, urea is so high. Somebody can come with double vision. You go and check, BP is high. You may have a child who is presenting with hearing loss. You take a good history and a physical examination and you find Alport syndrome there. You come to the skin, you see some skin lesions on somebody you think is okay. You do a workup and you find SLE. You may do an echo, you find a left ventricular hypertrophy. You think it's the heart. You take a good history and you realize that, hypertension is hiding in there. The person may even have anemia. You listen to the lungs, you find pulmonary edema. You think it's just simple fluid overload. You end up finding CKD. You may have somebody with arthritis, arthralgia. You may think it's just simple. You take a good history and you're looking at SLE. Somebody may come with anemia, leukopenia. You think, oh, this is a hematological condition. You go into details, you may find SLE. Somebody may come with polyuria. You think, oh, this is diabetes mellitus. You go in, you can find renal tubular acidosis. You may find somebody who has stunted growth, comes in, goes to endocrine, they do a workup, and you find small shrunken kidneys. So indeed, you find the kidney in almost every organ in the body. When you come to the symptoms, look, fever, headache, vomiting, diarrhea, taking out those which are specific to the kidney, they all point to a kidney disease. Somebody will be so breathless. The first person, if not very experienced, will think, oh, this is pure pneumonia. You listen to the chest entry is fine. There are no crepitations. You find metabolic acidosis there. So really, any symptom at all can be a sign of kidney disease. So Prof says that always think about the kidneys when evaluating any sick child, because something may be hiding in there for us. So I'll take you through briefly a few signs or symptoms. Slide is not moving. Okay, all right. Oligoanuria, I'm sure everybody has heard this before. Echo, I hope I can still be heard. Yeah.
Yes, go loud and clear.
All right, okay, all right. Quite a number of times, we receive a lot of referrals. You may see oliguria, anuria, oligoanuria. So really, it is something that is commonly encountered in the clinical care setting. And if you know about our AKI staging, it is an early biomarker of AKI. And there are various causes of oligoanuria. It can be clinically apparent or it may be subclinical. So what is oliguria? We define it as a urine output less than 0.5 mils per kilo per hour or 300 mils per meter square body surface area per day. You can just forget about that and do the mils per kilo per hour. Nephrology is full of calculations. So if your math is not good, you may be found wanting. So just stick to the mils per kg per hour. It's fine. When you go to infants, it is less than 1 ml per kilo per hour. So if you find any infant and urine output is 0.8, 0.7, 0.9, don't be too happy. It is a sign of oliguria. Anuria implies complete cessation of urine flow. It's simple. I mean, once you're not passing urine, this is anuria. Really, these definitions just help us to guide us as to how we manage our patients. But in general, any urine output that is insufficient to maintain the fluid balance homeostasis and also prevent volume overload can be deemed to be oligoanuria. So that if your intake and your outputs don't balance out, you should have a negative balance. If you take in, let's say 500, you are supposed to bring out 700,000 mils. If you take in 500 and you are bringing out 100, it is not enough. So be very mindful of that. So in this situation, you should always evaluate. Evaluate means take a very good history, do a thorough physical examination, and then come out with a diagnosis and manage based on what you find. Because if you are able to pick this early, it may help you to reverse oliguria and then prevent AKI, especially if it's a pre-renal or post-renal oliguria. Okay. So by way of etiology, we have classified oliguria into pre-renal, intrinsic renal, and then post-renal. When you come to pre-renal, hypovolemia is our number one. So your diarrhea, your vomiting, if you have tubulopathies like renal tubular acidosis, they may come in with hypovolemia because they urinate so much. If you give diuretics too much, your loop diuretics, if somebody has diabetes insipidus, it predisposes them to hypovolemia. So you should be mindful when you have children coming in with diarrhea, vomiting, they they are on diuretics, be mindful of hypovolemia. Again, blood loss, if there's a severe trauma or if they go for surgery and they bleed, it can also lead to a prerenal oliguria. And then when there's third spacing, the commonest we can all think of is nephrotic syndrome. When there are burns, sepsis, or decreased intake for whatever reason, it all leads to hypovolemic prerenal oliguria. Then you could have cardiogenic causes of oliguria. So congestive cardiac failure, pulmonary embolism, MI, especially in adults. Then congenital heart diseases. They all predispose you to prerenal oliguria. Then there are vascular causes of prerenal oliguria. So renal vein or renal artery stenosis, thromboembolism, capillary leak, neurogenic bladder, or anaphylactic shock. They all predispose you to prerenal oliguria. Then when it comes to intrinsic renal, glomerulonephritis, interstitial nephritis, acute tubular necrosis due to nephrotoxins and radiocontrast agents, or acute tubular necrosis due to prolonged prerenal failure, all predispose you to intrinsic renal oliguria. Then when it comes to post-renal, usually renal calculi, stones, lower urinary tract obstructions. Commonly, we see a lot of PUVs around us, neurogenic bladder, or a urethral trauma. It can all predispose you to post-renal oliguria. How do you assess oliguria? Don't mind my 2x4 table, just take the message on it. So when it comes to oligoanuria, always assess volume. Assess volume, take a good history, do a thorough physical examination. So in your physical examination, that is what you assess your volume. So if you have hypovolemia, my table says, look at the renal indices favoring prerenal etiology. Don't mind that. Examine the patient, feel the pulse, the skin turgor, look at the mucous membranes. How active is your patient? Mind you, I'm saying don't mind the table because these renal indices, I don't think I've even ever used them myself. It's usually for exams. We don't usually do it. The only thing I'll say use will be the specific gravity, urinary specific gravity. If you have a dipstick, you can, and you have some little urine, you can check that. Otherwise, use clinical signs, signs of dehydration. So your skin turgor, your mucous membranes, your capillary refill time, your pulse volume, the activity of the child. It will all point you to hypovolemia. You don't need the renal indices whilst you're standing by the patient's bedside. Then, if hypovolemia is confirmed, you give your intravenous fluid bolus. If you give your intravenous fluid bolus, you need to monitor. If you give your intravenous fluid volume and hydration has improved, then you are out of the woods. You can also give furosemide. If you examine you give your fluids and your intravascular volume is restored, you give fluids. Otherwise, please, Lasix shouldn't be your first to give. Make sure that you have restored volume before you give Lasix. If you assess and there's hypervolemia, the person may be edematous, BP may be high, then there's a need for diuretics. And then you restrict fluid and salt rather. If you assess and the person is euvolemic, then you do an ultrasound quickly. If your ultrasound is normal with or without increased echogenicity, then give fluids, but please monitor your output cautiously. If you find there's congestive cardiac failure, diuretics are indicated. If you institute all these things and still there's persistent oliguria or anuria, please involve the nephrologist. Don't wait too long. Give yourself 12 hours. If you do your ultrasound and it's abnormal, hydronephroureters, bladder wall thickened, bladder is distended, then you are looking at post-renal causes of your oliguria. So then you pass a catheter and then you observe for post-obstruction diuresis. And for this one, you always treat in consultation with the urologist. But again, we always follow up for the urologist when they are done. So these days, they pass their patients through us before they go for surgery. I've intentionally elaborated a lot on oliguria and anuria because it is one of the commonest we all face in our centers. My next is polyuria. Excessive urine output in a child is always a concern for every parent and is defined as consistent urine output of more than 4 ml per kg per hour in infants and children and more than 6 ml per kilo per hour in neonates. However, I should be able to differentiate polyuria from polacuria. I have this pastor who says when he's preaching, he usually brings huge words to sort of get everybody on course or to just excite people. Polacuria is just frequency. So if your child goes to the loo very frequently, it doesn't mean they have polyuria. Your urine output may or may not be increased. So polyuria is frequency. Polyuria can result from the intake of large quantities of water, that's primary polydipsia, or it could be from increased solute load, that is osmotic diuresis, and you find this in diabetes mellitus, mannitol infusion, and at times when you are in the recovery phase of AKI, they can have polyuria. And then another cause is water diuresis. It is just increased urine flow or urine output, which is caused by a decreased reabsorption of solute free water in the collecting ducts. And this happens in diabetes insipidus. So that is polyuria for you. How do you evaluate polyuria? If you find hyperglycemia and glycosuria, it is diabetes mellitus. Refer to the endocrinologist. If you do your urine RE and then there's proteinuria, there's glucose, you have a normal anion gap, and there's metabolic acidosis, always think of renal tubular acidosis. Please refer to us. Let me say here that renal tubular acidosis is in our system. They are all over. It's just that we treat all of them as failure to thrive, and it is always in the last minutes they land in our hands. So if you have any child, polyuria, polydipsia, failing to thrive, please send to us. We'll sort it out. If it's not that, we'll send back to you. Again, if you have hypernatremia, where your urine osmolality is less than your serum osmolality, think of diabetes insipidus. Refer to us. We'll sort it out with the endocrinologist. If you have hypokalemia, hypochloremia, metabolic alkalosis, please refer to us. It is Bartter syndrome, Gittelman syndrome. So refer to us. If you find any of these things, we'll sort it out. If we stabilize the patient for follow-up purposes, we may come back to you or we'll keep the patient. Edema. I'm sure we all know edema in an African context. It means that you are cursed or you have done something and a river body has also done something to you. But to us, it is a cardinal sign of renal disease. And edema is just an abnormal collection of fluid within the interstitial tissue. And it's usually associated with effusion. So you may have somebody who has edema, and there will be third spacing of this fluid in the pleural space, in the peritoneum ascites, or in the heart, pericardial effusion. When you have massive severe edema, you have anasarca. So that's where you become so turgid, your face, your abdomen, your feet, you are all swollen up and you'll be leaking fluid left and right. Take note that edema can be inflammatory or non-inflammatory. For renal edema, it is non-inflammatory, same as hepatic, cardiac, angioedema, and then lymph obstruction, and then hypoproteinemia. For exam purposes, inflammatory edema is usually exudative, and then non-inflammatory edema is usually transudative. Inflammatory edema is usually localized and is usually associated with, if you remember pathology, rubor, dolor, calor, and tumor. That is redness, pain, heat, and swelling. Non-inflammatory edema is usually generalized. It is not localized. And the commonest causes or the renal causes of edema that I'm sure we are all familiar with are nephrotic syndrome, AKI. In nephrotic syndrome, the edema can really be generalized and you may have anasarca. In AKI, it is usually not severe edema. In AKI, you're not supposed to find, say, scrotal edema and all that, same as AGN. But in nephrotic syndrome, you are likely to find scrotal edema. Edema can also occur in end-stage kidney disease. When we say renal edema, it appears initially in parts of the body with loose connective tissue and is gravity dependent. That's why it has a characteristic feature of onset around the eyelids during awakening. That's why we always say early morning facial puffiness. And then it disappears with erect posture to accumulate in the legs by the end of the day. So that is renal edema. To confirm it is really renal edema, there may be hematuria, oliguria, with or without hypertension. And then your treatment of edema is usually by symptomatic management and treating the specific cause. So once you take your history, you examine and you find the cause. If it's nephrotic syndrome, you treat as such with your steroids. If it's nephritic syndrome, you give your diuretics. If it is end-stage kidney disease, then you evaluate further and institute the appropriate measures. So how do you manage edema symptomatically? So there are a number of school of thoughts. They say bed rest. And what bed rest does is it alleviates the orthostatic activation of the renin-angiotensin and sympathetic nervous systems that accompany upright posture. And then it facilitates the transfer of interstitial fluid to the vascular compartment so that you'll be able to expand your circulatory volume. So when you have edema and you rest, you expand your circulatory volume. However, there's a big but. Prolonged bed rest also causes venous stasis and is associated with increased risk of thromboembolic complications, especially nephrotic syndrome, due to the underlying hypercoagulable state. So there should always be a careful balance between bed rest and activity so that you'll be able to avoid venous stasis. Then salt and fluid restriction. You know, the primary mechanism of renal edema is salt and water retention, so that there should be a combined restriction of these two, and it aids in the slowing down the rate of your edema formation. Again, if you don't restrict both, your therapy will be ineffective. And so the practical advice when it comes to salt restriction is to say that do not add salt or extra salt to your diet. And then the use of table salt and processed food with high salt content should be avoided. This is to ensure that the diet is practical and you don't sort of restrict unnecessarily. The only time when you would have to restrict salt like no sort you really quantify for them is when there's resistant edema. So you have your edema, it is not resolving, then you will be very clear with your salt and fluid restriction. And then in your fluid restriction, you should restrict either to insensible loss, 400, some will say 300 to 500 mils per meter square per day, depending on where you find yourself. So if you are in a cold country, you can do less. If you are in a country, you can do more. Or you restrict to insensible loss plus your previous day's urine outputs, depending on the severity of your edema. So that's what you do. Then when it comes to diuretics in your symptomatic management, some schools of thought will say it is the cornerstone for the management of moderate to severe nephrotic syndrome, but they are only useful when the intravascular status is maintained or is high. So you can only give diuretics in nephrotics when you are euvolemic or hypervolemic, because you know nephrotics can have hypovolemia. And then your choice of diuretic, your route of administration, and then your dose of administration should always be decided and titrated based on the severity of your edema and then your response to your therapy. When it comes to albumin, it shouldn't be given routinely. It is usually given in refractory edema. That is, if your edema is not responding to effective diuretic doses. I hope I can still be heard. Echo,
Yes,
can I?
Dr. Nima, yes, you can be heard loud and clear.
All right, okay. A moment, please. All right. So when it comes to proteinuria, proteinuria is a marker of kidney disorders of diverse etiologies. In fact, when you see protein in your urine, you should always think of kidney until proven otherwise. Although we know that it is the result of kidney disease, it also hastens the progression of renal damage. So in nephrology, in fact, we fight proteinuria with our tooth and nail and everything because we don't want to see it in the urine. When we say physiological proteinuria, it is usually less than 100 milligram per meter square per day per 24 hours. And this proteinuria, it is not from your glomerular filtration. It is from shedding of tubular cells. So take note of that. It is not from glomerular filtration, because if you know your glomerular basement membrane, it doesn't allow protein to filter through unless there's a problem. Then there's pathological proteinuria. Pathological proteinuria is when your urine protein is more than 100 to 150 milligram per meter square per day. And then there's nephrotic range proteinuria, where the proteinuria is more than 1,000 milligram per meter square per day, or 40 milligram per meter square per hour, or 50 milligram per meter square per 24 hours. Don't mind the math. You can always depend on your urine dipstick and proteinuria. I'll share that one in the next slide. Proteinuria is pathological or non-pathological. So when it's pathological, it's usually from your glomerular disorders or from a tubular problem. So the commonest glomerular disorders we know are nephrotic syndrome, nephritic syndrome, acute glomerulonephritis, end-stage kidney disease, all that are glomerular. And then your non-glomerular, commonest you can think of is renal tubular acidosis, Bartter syndrome, all those ones are tubular. And then when we say non-pathological, you may be leaking protein, but it doesn't have any effect on your kidney. So that's why we say it's non-pathological. So there are two of them. One is transient proteinuria. When we say transient proteinuria, it means it's brief. It has to go away. And it goes away when the condition that brings it about resolves. So for example, if you do strenuous exercise, you may have transient proteinuria. If you have a fever, if you have seizures, if you have a congestive cardiac failure, you could have transient proteinuria. And usually the protein in the urine is less than 2 pluses. And it is not associated with edema, hematuria, hypertension, or renal failure. So if you say transient proteinuria, it shouldn't come with any sign of kidney disease. And then there's orthostatic proteinuria. It is isolated proteinuria without hematuria. And it usually occurs when you take a random specimen collected from a patient during daytime. And the patient should be asymptomatic. So you don't say orthostatic proteinuria in a nephrotic syndrome patient or a nephritic syndrome or somebody who has AKI or end-stage kidney disease. The person should be asymptomatic. So anybody walking about, you just say, come, let me test your urine, and you find urine protein without hematuria, there are no symptoms of kidney disease. It is orthostatic proteinuria. It is usually significant proteinuria. If you want to be sure it is orthostatic proteinuria, you should do an early morning urine testing. So as soon as they wake up from bed, you let them pee and then you test that urine. And then when you test that urine, it's normal. You won't find any protein in that urine. But as the day goes by, that same person, if they've walked about for some time, if you test their urine, you will find proteinuria. And it's usually common in about 20% of children and more common in boys above 10 years than girls. And it is benign. It has no clinical significance. However, because it is proteinuria, you should always, if you diagnose orthostatic proteinuria, every year you should test the urine of that child until the 3rd decade. So it's no joke. We don't joke with protein in the urine. So you test that until the 3rd decade for that child. Okay, so yes, so I brought this urine dipstick. I'm sure everybody has urine dipstick. I usually tell my patients that even if you live in the remotest part of whichever place you find yourself, you can always do urine dipstick. Whether you are educated or not educated, you can always do urine dipstick. So if you're in a health center or you are in a tertiary hospital, you should always have a urine dipstick. And it is a semi-quantitative assessment of proteinuria. So you can use this one instead of the milligram per meter square body surface area that I mentioned in the previous slide. Negative is negative. Usually the ones we have in health facilities are the combi-10. So it has 10 parameters on the dipstick. And then per the manufacturer's instruction, they'll let you know when to read which parameter. So it starts from maybe 30 seconds to 120 seconds, which is 2 minutes. So always correlate with the instructions on the bottle, because there are various brands on the market, and always read the instructions. So negative is negative. I'm sure we'll run through all of them. Trace means that your urine protein is 15 to 30 milligram per deciliter. When you have 1 plus, it is 30 to 100 milligram per deciliter. 2 plus, 3 plus, 4 plus, and onwards. So when you have usually 3 plus or 4 plus, we say nephrotic syndrome, nephrotic range proteinuria. But you can see for 3 plus, the range is so wide. And then when you have 2 plus or less, it is nephritic syndrome range. Okay. Hematuria. So we say somebody has hematuria when you have done a urine dipstick and it's positive on the dipstick, and then you do microscopy and you find RBCs of more than 5 per high power field. on microscopy, and then that is significant hematuria. And usually it's an indication of a glomerular or a non-glomerular abnormality until proven otherwise. It could be macroscopic or microscopic. When we say macroscopic, it means that, I mean, you see the urine and it's all blood, it looks red like blood. Or it could be cola-like or rusty or tea-colored. When you see a macroscopic hematuria and it's bright red in color, or there are blood clots in it, it's suggestive of a non-glomerular disease. So it's not coming from high up the glomerulus. So it could be from the bladder, from the urethra, down there. And then when you see macroscopic hematuria, so when you see the urine and it's tea-colored, it's dirty brown, it's rusty, it's because there's been oxidation of the heme pigment. For that one, it is a glomerular hematuria. It's coming from high up in the glomerulus. So take note of that. When we say microscopic hematuria, when the person passes the urine, you don't see whether it's tea-colored or it's bright red. It looks like normal urine color. It is only dipstick that will suggest that there's blood in the urine. And then when you do your microscopy, you see significant proteinuria, which is more than 5 per high power field. And it may be asymptomatic, or it can come with proteinuria. And then if it's from a glomerular disease, you may have oliguria associated with it. You may have edema, you may have hypertension, you may have a rash or arthralgia. So usually for these ones, you may see them SLE. They may not show any blood, but you do your dipstick and your microscopy and it is there. If it's from a non-glomerular cause, you may find dysuria, frequency, urgency, which may be pointing to a UTI. Hematuria may also be transient hematuria. So it may be from an inciting event, and this should resolve once that event is over. So let's say you give certain drugs, infections, trauma, exercise. And when we say transient hematuria, it is usually microscopic and benign. So once you see macroscopic, you can't say it's transient. Once you see bright red blood in the urine or it is tea-colored, you cannot say it's transient. It has to be microscopic and it is usually benign. And then there's persistent hematuria. It is also microscopic hematuria, and it should be, you can only say it's persistent when you do at least 2 to 3 urine analysis over a period of 2 to 3 weeks. Then you say it is persistent hematuria. So you cannot do one today and tomorrow you do another one, and then you say this is persistent hematuria. No, it has to be over a period of 2 to 3 weeks. There could also be isolated hematuria. When we say isolated hematuria, it means that there's presence of RBCs in the urine with no other urinary abnormality. So there's no proteinuria and there's no raised serum creatinine. There's no high blood pressure. And for this one, it could be gross or microscopic. So once you get that and you've done all your investigations, nothing points to any kidney condition, you can say that this is isolated hematuria. And for these ones, you need a long-term follow-up until it disappears. Or as you are following them up, it can evolve and the child may develop additional renal or other systemic abnormalities. So once you see isolated hematuria, don't let it go. You have to do a long-term follow-up until resolution or symptoms evolve. Hematuria could also be initial. When we say initial, that is when, as soon as you start urinating, you see the blood, and it's usually suggestive of a urethral injury that is distal to the external urinary sphincter because of probably a foreign body or trauma. It could be terminal, with or without dysuria. And for terminal, it's after you finish urinating, then you see a few drops of fresh blood after your urination. This is what we usually see in urinary schistosomiasis or in bulbar or prostatic urethral injury. And then it could be total. So when you have all the urine being bloody, then we say that is total hematuria. And it could be from a glomerular or a non-glomerular cause. So usually some of the causes of hematuria are infection-related glomerulonephritis, chronic glomerulonephritis, HUS, stones, lupus nephritis, of course, our nephrotic syndrome and our nephritic syndrome are also in there. Okay. So my last is failure to thrive. I remember when we started work as a house officer, we used to see a lot of failure to thrive children, and most of them ended up having PUV and all that. Way back, I remember now with what I know, there was one condition that was a renal tubular acidosis. And failure to thrive or growth retardation may be the only manifestation of kidney disease in infants and toddlers. And even for older children, we've seen quite a number of kids, they look very small, and you may see the parents, they also look small. So you think, oh, this is genetic. But recently we found one, it was end-stage kidney disease. And for failure to thrive, the renal causes are considered under 3 broad categories. I'll not go into detail because this is just specific to nephrology, but just to have a fair idea so that wherever you find yourself, if you find you see these signs or symptoms in a patient, you at least know what to do. So there's CKD, and it comes with a triad of manifestations of growth failure, anemia, and bony deformities. These days, we hardly see these bony deformities because I think people have been enlightened about CKD enough. But anemia is so common, growth failure is so common. And then Kakut, so almighty PUV, vesico-ureteric reflux, obstructive voiding symptoms, poor stream, dribbling, pyuria. If you see growth failure or failure to thrive in any child. Then renal tubulopathies, failure to thrive, which is associated with polyuria, polydipsia, dehydration, metabolic acidosis, hyperchloremia. So, I mean, if you see anybody with failure to thrive, please don't forget us. I mean, don't forget the kidney. Probe further, take a very good history, examine further, and it may be just the pointer you need for a kidney condition. So in conclusion, I would say that anything at all can be a sign or a symptom of a kidney disease. Take a very good history, do a thorough physical examination, and once you do the 2, adding your investigations will always, most of the time, give you your diagnosis, whether it's from a kidney cause or whatever. So don't see any child with fever and think, oh, this is malaria. Please probe further. It may be a UTI, which may be a sinister cause of something hidden somewhere. And so with that, I say thank you, and I hope I've been able to educate you. Over, Echo.
Thank you so much.
Echo, please. Over.
Yes, I can hear you. Yeah,
All right.
about
Okay. Okay.
Thank you so much. And please follow online.
Hmm? Hey. Echo, if somebody is talking, I can't hear you. Hey. Echo, can I be heard? Is it from me or?
Can we be heard now?
Pardon?
Hello. Hello.
Yes,
Dr.
hello.
Nema, yes. I think there was a slight issue with our microphone, but it's been sorted out now.
All right. Okay. Okay.
Yes, please. I hope you hear. Okay, great. Good. So we'll
Yes.
take the next presentation on drugs and the kidney to be presented by Professor Samson Entry. Like I said initially, Professor needs no introduction. Yes, yes. It says actually introduce him.
Oh, please
So I'll hand
introduce.
over the mic to please don't forget to put your questions in the chat box because we'll be answering them during the Q&A sessions afterwards. So go ahead.
Okay.
Prof, yeah, let us introduce you. Why?
You can take this one, isn't it? Okay. Come forward now. We are sitting at the back, so how do you want me to be shouting? Come, we are empty seats here. Please, all of you come forward. So, Mami and thank you very much. I think for us, that lecture on manifestation of kidney disease is very important. It is so important for us because, I mean, most children, it is when they come brief and they are swelling. That is why people know that probably there's something wrong with the child and it may be too late. And so all those subtle things you talk about, particularly failure to drive. Just some 6 months ago, a colleague of mine who is also a doctor, I got a child who is actually failing to drive. He's so small at 12 years. And he tells me that anytime they go on the table, they eat together like this. That child is just a picky eater. He just do this one. So he thinks that child doesn't like food. Until one weekend, he called me that he's realized that the child had either edema. And so when I asked her to do initial labs and bring the child to me, when he came, I was even praying because I have blood protein in the urine. And the father tells me that he had been having recurrent tonsillitis, has even moved tons. So I was only hoping that this is a post-stress, when the creatinine was in the thousands. But we did the ultrasound, and it was end-stage, very shrinking kidney. So this child had been having all this, not eating, not feeling, is not thriving. It was something that they have sought a pediatrician. And I'm sure when they came to you, probably going to give multivitamins and then send the person home. You understand? And so these subtle changes, please. And invariably, urine dipstick is a very simple test you can do. It can give you a fair idea what is happening. And so those subtle things that they talk about very important for us. You don't wait till the person is swelling. It may be too late, it may be end stage. And so let's take, and if you see anybody's urine blood protein, it is a marker of kidney disease. When Aduma was a resident, don't time you haven't started. When Aduma Okuyo was a resident, that time we used to go to room 2 polyclinic. There was a child here that were overseeing that. So he calls me and says, boss, there's a patient I'm reviewing. And when I look at the folder, anytime they do the urine dipstick, the specific gravity is 1.000. So he reviewed it and saw multiple times. Could this be diabetes insipidus? And indeed it was. They admitted that child for diabetes insipidus. Just by urine dipstick. I'm sure people don't pay attention. Just like you're doing ward rounds, and they say somebody's pale. I say, okay. So what is the MCV? Then you go and look at it, it is 60. The doctor has not even seen it. My daughter has not even seen it. They have been suspecting somebody has got passage disease, either it's a hookworm, whatever. So what is the eosinophil? They don't look at it. You go and look at it. I think it's 12%. They don't pay attention to this. So me, after that is fine, but all the things he said, subtle things.
Please, let's pay attention to it. And when labs come, let us actually analyze it very well. Instead of just looking at the HB and then that is the end of it. There are many information you can get on the full blood count. And let's pay attention to these things. So most of the things probably you know, it was just for emphasis we have said it. And I'm sure what I'm going to take you through, unfortunately, I couldn't do it when we did the kidney update at the pediatric conference because I had to travel. And I was telling them that that would be probably the new thing people will learn. And so for today, those here and those online, what I'm going to take you through may be a new thing you will learn in your career. And they are very, very important because don't pay attention to these things. Sometimes we, as practitioners, we also add injury to people's kidney when they come to us because we don't pay attention to certain things. So drugs and the kidney. Now you can tell me how many minutes have you given to me? When I came here, you were talking and he talked for 45 minutes. When I was sitting here, I sat here for 45 minutes. Anyway, let's see how it goes.
Professor.
So this is the outline. Kidney's role in drug metabolism and the need to do adjustment in the setting of kidney failure. I think you speak for yourself. Sometimes we are so lazy to open BNF and see what is. But there's a whole appendix that tells you those adjustments in renal failure, in whatever this is. But we are so lazy to just open and look at that. Let's do that. And then mechanism of kidney-induced, drug-induced kidney injury. In the setting of hemodynamic instability, so it goes to Dave and Eugene, because they are all dealing with people who have got hemodynamic instability. Anybody with critical ill, it means that your hemodynamic system is challenged. That's the simple truth.
Prof, are your slides moving?
Huh?
Are your slides moving? We can't see it moving here. Please, somebody should check for us. Those online, yes.
Okay.
Okay.
Are you working on that? So I'll talk about how drugs we give cause kidney injury in these settings. One is if somebody has got hemodynamic instability, then certain drugs that you think they are not nephrotoxic become nephrotoxic because they are hemodynamic unstable, and we need to pay attention to that. Then another thing will be acute necrosis. Some of these things are drugs that are nephrotoxic themselves. So those ones, sometimes we know that these drugs are nephrotoxic. So they can cause acute necrosis. And then any drug at all can cause acute hypersensitivity nephritis, what we call tuberous nephritis. Any drug can cause that. So we look at a few. And then there are certain drugs that also cause crystals to form in the kidneys, akin to how hemoglobinuria forms crystals. Hemoglobinuria is the most common cause of acute kidney injury in our setting for 12 years that we have done analysis. All the time, every year, hemoglobinuria. And so if you see a child with hemoglobinuria, I remember Dr. J, when he was a resident that time, I went to PU one time to go and review cases. He was Prof, this child, he came with hemoglobinuria. Look at the urine. Have you done the kidney function? Have you checked the urine? No. And the child, when I turned to the child, he was already lethargic. The child was lethargic. Hemoglobinuria, you know the creatinine was 3,000. 3,000. Sitting there. And so crystal formation, certain drugs inherently cause crystal. So when you give it, then you need to either give a lot of fluid to flush it or not. So this is a common knowledge. But among the things that kidney does, it's not only, when we say metabolic waste, not only urea creatine, drug metabolism. When drugs are metabolized, it's the kidney and to some extent also the liver. Some drugs are also excreted by the liver. But largely it is the kidney that will excrete the metabolites. That's what it does. But certain drugs also, like the penicillins, they are excreted to the kidneys on change. And so if you are working in a place where you have pressure, somebody comes pneumonia, is dying, and then you haven't got drugs there, and then somebody comes and says, oh, he's taking penicillin for some boy that got here. You can actually collect that person's urine and then give to that child. You can save the person, I'm telling you. Because you go to die from the pneumonia, so we let them drink it. I'm not preaching urine drinking. Those who know, I'm not part of them. I'm only telling you that penicillins are usually passed through unchanged. So they are say bioactive. So it means that in the event of a failing kidney function, drugs that are filtered or those that are metabolized can accumulate to toxic level. Simple as that. Penicillins, as you know, don't cause, haven't got any problems. And so for me, there's nothing like overdose. Penicillin, you can give and give and give. You only fear penicillin for two things. If somebody reacts hypersensitive reaction to it, that one doesn't depend on the dose. So there's actually not overdose. But if the person has got a kidney failure, they are not secreted, so then that becomes this thing and can actually cause encephalopathy when they accumulate. Otherwise, penicillin, they overdose. Unlike other drugs that if you mix the dose or you give too much dose, can cause this one. So understand that because the kidney excretes certain drugs, either the raw drug or the metabolite, if the kidney fails in function, then those things will accumulate. Simple reason. And that is why BNF has dedicated an appendix. And they say, when there's a kidney failure, they will tell you, based upon the range of kidney failure, what adjustment to do. But like I've said, the problem with us is that sometimes we feel lazy to open the book, look at it. There are certain drugs called de novo kidney injury. I mean, these are inherently. And some of them too, not that inherently they are nephrotoxic, but under special circumstances. And what I said was hemodynamic instability. When there's a decreased blood flow or when there's dehydration, then they can cause. Ordinarily, they are not nephrotoxic, see. And we go through them, we look at mechanism. But I'll talk about the others. The hypersensitive ones are idiosyncratic. You can't predict. So you give it, and the person reacts. And then those that crystallize. So these are the four mechanisms. De novo, nephrotoxic, when there's hemodynamic instability, hypersensitivity, and crystallization. And these are the four mechanisms that my lecture will focus on. So the first one is, so first principle in drug administration, as far as the kidney is concerned, is in the event of kidney failure, check the recommendation on the drug administered to the patient. Do not administer such drug. Some of them, if you check the recommendation in BNF, they will tell you don't give. So use alternate drug. Is that okay? So let's do that. Others, you can administer, but you kill the dose whilst maintaining the interval. So the drug is naturally given 12 hourly. You can give it 12 hourly, but you reduce the dose. All those things are written in BNF. And then the others that you can administer the same dose, but then you increase the frequency. So instead of giving BD, you can say that give it daily or 18 hourly. These things are all documented in BNF. And so the message is that once a person you are dealing with has got a kidney problem, you are giving medication, check what is the recommendation about adjustment. In some of the drugs that are de novo or inherently toxic, like glycosides, ordinarily you need to do drug levels. You can give probably the first dose of the drug, but you can't give the repeat dose unless you have seen the serum concentration. That's going to guide you as you give it. I remember when I came initially, I wanted to do for gentamicin. So somebody in this one, and then I got infection that we need gentamicin to treat it. So we give it the first dose, and then I sent a sample to Lancet, because Lancet is in South Africa, so I thought they do that. They said, yeah, can you do? Then they told me it would take 2 weeks. When I need the thing to decide the next day, they do. So since then, that was 2009, since I came, I've never attempted to go and check drug dose. In fact, recently I recommended to pharmacy and all the people there that can't they even begin to do some of these commercial things for us? Pharmacy and biochemistry, that certain drug dosages, can't they do it for us? Whoever can get it in 2 days, 3 days, that is not bad, even idea. So in South Africa, that's what we used to do. So you always get the dose. So when you take it, then you will get a level, and then depends on the level, you can give the next day. But here we can do it. And so probably you get the first dose, and that first dose may linger on in the system one because the kidney is failing. So you go and do a second dose, then you see, going to escalate the levels. And that is why those who have been following me when I do what rounds, Sometimes when we are hard pressed, the person has got a very terrible infection, we have to give amikacin, and I say, probably give first dose. Not a very high dose, probably a small dose. But give it and don't let us give again. It will be the system start to work. So these are the principles I want to talk about. So for potential nephrotoxic drugs, monitor the kidney function closely. If you give any, there are a lot of people on gentamicin and amikacin, you give them. Okay, ideally you should be doing levels. But if you don't do, let us also monitor the kidney function. Incidentally, those drugs affect the proximal tubules, and so they are not oliguric, they don't cause oliguric renal failure. And so if you are looking at only the urine output, it will deceive you. I'm telling you about the monoglycosides because they affect the proximal tubule, and they don't cause oliguria. So if you want to depend on the urine level, so you need to do the right thing. I remember when we did 0/25 study. And so among the people we screened for were people monoglycosides. You take the creatinine, then you repeat it to see whether you are causing injury. So it's the serial creatinine you take, that's to tell you whether the monoglycoside is causing injury, not the urine output. So if you can monitor drug levels, yes, do, but you can't. And eliminate any condition that facilitates the nephrotoxicity. So if there are risk factors, just try and eliminate. These are the principles. So let us look at the ADB patient, the hemodynamically unstable patient. I'll show you the mechanisms. No, not anybody who got critical ill. That's the thing. Critical ill patient, hemodynamically, you struggle. A lot of organs are not functioning very well, but we have a challenge. And that is why in my lecture, I always the students will get it, that we walk into the emergency unit, what child deserves close monitoring for kidney function because it's at risk. And one of the things I've written, any child who is sick enough, you seek ICU care. And ICU, nobody works in ICU. They are monitoring liver function and kidney function. After all, how do we define critical ill? The person has got multi-organ dysfunction. So the kidney, the liver, so you need to monitor. So they are all critical ill. To take note. So if the person is hemodynamically unstable, the drugs to avoid are 1, ACE inhibition and ARB blockers. I'll show you a diagram to explain that to you. Don't give that. If somebody's got hypertension, don't give that. Somebody got dehydration, don't give that. Somebody got shock, don't give that. The same thing with NSAID. When we say NSAID, don't get bruising, talking about those drugs. Okay? Acute, they're not nephrotoxic, but if somebody has got hemodynamic instability, don't give those ones because you cause injury. I'll show you the mechanism. And the same thing with calcineurin inhibitors. We don't use it a lot here. Some of our nephrotics will be on it, and of course, people on transplant. And then, so these are the classification of drug-induced. Those that are hemodynamically unstable. And then those that cause nephrotoxicity, what are caused, these are, either acute necrosis or interstitial nephritis, which is hypersensitivity. And then the crystal ones. So how does NSAID and the ACE inhibition cause kidney injury? Let me try and explain this to you. You know what we call autoregulation of the kidney. So a kidney actually is a nephron. A nephron is a glomerulus and a tubule. That's all it is. Glomerulus and a tubule. The glomerulus have got afferent arteriole and efferent arteriole, and the capillaries are interspersed between the two. Naturally, the afferent arteriole is bigger than the efferent arteriole. So you see what will happen. It will help you to build pressure because more blood is going in than is going out. So that pressure will be built in the glomerulus, and that is how the kidney are done to filter, so that it filters. So that is how it is done. But then there are other mediators, drugs, hormones that the body produces to try and maintain that. So if something happens and the perfusion of the kidney is reduced because you have vomited, diarrhea, or you are sick, sepsis, and you have got low blood pressure, the perfusion is reduced. How would the glomerulus maintain the pressure to filter? So what it does is that it will cause angiotensin II to be released from the renin apparatus. That apparatus is called RAS, renin, angiotensin, aldosterone. What that's this? Once there's hypovolemia, so angiotensin II will then be secreted. When it comes, it got receptors both at the afferent and the efferent, but there are more receptors on the efferent. So when they go and bind to it, it causes the efferent to become smaller, further smaller. So even if what is going in is reduced. Because this one becomes very smaller, pressure is built up, then the kidney filters. Do you understand? So if you go and give ACE inhibition or angiotensin receptor blocker, in that setting where there's hypoperfusion, what's hypovolemia or this, you know what you do? You will diffuse that pressure in the glomerulus and the kidney will not filter. And that is why there's a test we call captopril test. Captopril test. Captopril is ACE inhibitor, short acting. We use it to test for unilateral renal angle stenosis. You suspect what does it renal artery stenosis, renal artery stenosis. Because that one is stenotic, so the blood-brain tray is small. So those people naturally secrete a lot of angiotensin, so that kidney will function. That's why they get hypertension. That is why renal artery stenosis causes hypertension, because angiotensin driven. And so, if you go and give angiotensin receptor blocker, you block it, you diffuse the pressure. And so what they do is that they will do a nuclear imaging, they will see both kidneys. Even though this one may be probably smaller kidney, but it's there. Then they will give captopril, and then they repeat the nuclear imaging. Then the one that got the stenosis, because it depends on angiotensin, you have blocked it. That one will not show. So you have two series of nuclear imaging. The first one, both kidneys are showing. You give captopril, and then only one kidney is showing. It tells you that that kidney has probably artery stenosis. That's the captopril test. So it's positive. So you know whether. So the same principle, you won't go and give ACE inhibition or AR blocker in anybody who has gotten this. And that is why ACE inhibition, even though they are the drug to give, if there's a unilateral renal artery stenosis, the BP cannot be controlled. That's the drug to give to control the BP. But you sacrifice that kidney. By contraindicated in bilateral renal artery stenosis, because you sacrifice both kidneys. And that is why we also don't give ACE inhibition in a single kidney. Don't go and give it. I mean, a transplant kidney, don't go and give that one. Because actually, ACE inhibition is termed medical nephrectomy. If you give ACE inhibition, because we are reducing the pressure, and therefore the function of this. So that's what we call it. So people like Bartter syndrome and people like congenital nephrotic syndrome, we give that. We want to cause medical nephrectomy because elsewhere they will take off their kidneys. They are losing all their protein and all the good things in their urine. They will take off the kidney and put them on dialysis. But among the medical management, you do medical nephrectomy, you give ACE inhibition to anybody who is passing so much. Bartter syndrome is losing so much salt that they will die. And also congenital nephrotic syndrome. So we give medical nephrectomy, ACE inhibition. So please, once somebody has got diarrhea, vomiting, so even for the adults who are giving these things, and even for the children, for BP control, tell them that if you get diarrhea, they shouldn't take the drug for that period when they have got diarrhea or vomiting and those things. So please, let's take note of that. So that is how it is done. By the same reasoning, I've talked about the efferent arteriole and angiotensin 2. By the same reasoning, once there's a poor perfusion, the kidneys will secrete prostaglandins. We call it prostaglandin I2 and E2. And those prostaglandins, they are made in the kidney. They will act on the afferent arteriole to dilate it further so that more blood can pass through. So that if more blood is passing through and you have not even adjusted the efferent, pressure will build up, the kidney will function. Do you understand? So in the setting of hemodynamic instability, when the kidney is surviving on the dilatation that prostaglandin has caused in the afferent, you go and give ACE inhibition, you also cause a kidney damage. By the same reasoning that ACE inhibition causes the damage. Is that clear? So these are things let's take note of, so that you are careful with what inside and the rest you do. Okay, but having said that, so these are acute settings when there's hemodynamic instability. But if anybody uses NSAID for a very long time, that one will also damage your kidney. That's why you don't need hemodynamic instability to damage your kidney. In fact, a retired police officer came to me, and for 5 years, every day he takes diclofenac and there's a cotton. Every day for 5 years. 5 years, every day. He never missed it. I said, I'm far. 5 years. So you can be sure the kidney was gone. So when it came on end stage, where we sustain the person by putting those dialysis were not free. So he couldn't afford dialysis. Finally, he died. The NSAID has chopped off the kidney. And so prolonged NSAID use. And people who habitually take it, and I tell people, there's what we call, where we need one, they call it what, popcorn. We call ours in Chile, isn't it? And so people who take NSAID like in Chile, you see also, for some people, especially the manual workers, farm workers, and the rest, as soon as they come, they are damaging their kidneys. So that one is not dependent on hemodynamic instability. So prolonged use will also cause damage. And let us take note and advise people. And when I talk about the hypersensitivity nephritis, NSAID can also cause that. In fact, in adults, NSAID-induced hypersensitivity nephritis is very common. Adults. Somebody take brufen, then suddenly he's not urinating very well, and then you see that he got this. In fact, there was one doctor, he's now in Bekwai. He did ONG. It was called, is it Abana or Akosia? All confused them because in their class there was one Abana, there was one Akosia. One is in the UK, one is here. They were doing a study. It's Abana. The one here is Abana, that back one. Then no one if I'm not Akosia. They were doing a study, malaria study in Kintampo. Then he called me, Prof. They gave the malaria drug, the intervention, listen, and the child did not urinate. So he called me, and so we got NSAID. He got a thing, 200 nephritis, bring the child. And indeed, it was. I dialyzed the child, I did biopsy, and confirmed acute interstitial nephritis. And so, NSAID can also, and many other drugs, as soon as you take it, and I'm saying in adults, very common cause of AKI. And so let us take note of these things. So sometimes some of the children that we are dealing with, you need to check your medication. Probably some of these things, of course. The clue may be eosinophilia. The hypersensitivity nephritis, it is actually eosinophilic nephritis. And they say that, of course, we diagnose it by biopsy. If you do biopsy, you see eosinophils infiltrating the kidneys, the two decision. But the urine, they will have WBC. So it is a sterile pyuria. Anytime you see sterile pyuria, you are thinking about nephritis. And those WBCs are actually eosinophils if you use special stain. And they say that some of them may also have some blood eosinophilia. So sometimes you can use all these things to try and check what you are dealing with. You see that the blood, you got high eosinophil. The leukocyturia they are getting is actually eosinophilia. And if you do biopsy, you see eosinophils at this thing. So that's the auto-regulation. So here I've talked about them, so I don't need to have to explain them well. So I'll talk about the captopril test. That's the basis of that. And these are prostaglandin E2 and I2. They are also dilators, so you must know. They act on the afferent artery. And I think when I taught the primaries, those who are doing primaries for Kanakali, I stress this. No, I didn't talk about this. I talk about it. I talk about auto-regulation. So if you are a primary candidate, I bring lots of questions around this for you to know. But they are the basic things. Yes, so I've explained all these things. This is the diagram I'm trying to tell you. Look at this diagram. So naturally, this is the afferent, is bigger than efferent, and therefore pressure is built up. But beside that, angiotensin 2 is available to constrain this further. Okay? And prostaglandin E2 and I2 is available to dilate this further. Do you see them the way it is? And so if you block this, okay, then it doesn't dilate, then it causes kidney injury. In the setting of reduced this, and when the kidney will survive, when there's dilatation, we are going to block that. The kidney will not survive. Okay, so either using NSAID or COX-2 inhibitors, they will cause that, and they will cause this. So that's how it is like. And so the person's urine output to go down. This is not. So this is for the NSAID. So all these things are there. And the risk factors are the aged. So not anybody who is more than 60 years. It's amazing. Very soon I'm going to hit 60. I'm telling you. So every day when you wake up and then you are waking up, then you are heading towards the end of the distance. I'm going to hit 60. And then I said, you see me, oh God. So the aged are at risk. And you know the problem with the aged, because of arthritis. So they are the people, because of arthritis, they are pushing NSAID, the strong ones, to them. And they are at huge risk. Cause a lot of problems. So let's be careful. So in fact, most nephrologists, they will say that painkillers are actually kidney killers. Painkillers. They are kidney killers. I'm confused when someone was so angry, they should be telling those geriatrics, they should not be giving the NSAID to this thing. But the person that comes also terrible how basically it can work. So it's a problem. So I always tell them that I'll give you the drug, probably drink a lot of water, probably for 3 days. When the pain goes down, stop it. Not antibiotics that we need to complete it. And sometimes we fail to tell them that. So for painkillers, when they take it, the pain goes down, tell them to stop it. Stop it. They can go for lesser things like paracetamol. I don't call it. Wonderful. Wonderful. So that is the risk factors. Anybody who has also got hepatic disease, fasciitis, because hypovolemia, remember, hypovolemia. Let me talk about hepatorenal syndrome, commonly liver disease, fasciitis, because of volume issues. So how do we prevent it? If you can use alternate analgesic, use it. And then use it for other decrease the dose or short duration. Like I'm saying, I will tell them 2-3 days, once the pain go down, stop it. Stop it. So let's do that. And avoid the potent one. You know, for all the NSAID, the most potent anti-inflammatory one is indomethacin. You understand? And for us, when we want to cause medical nephrectomy, we give both NSAID and ACE inhibition. I'm telling you, Bartter syndrome and congenital nephrotic syndrome. We don't give brufen. It's indomethacin and lisinopril or whatever. But we want to cause medical nephrectomy. Kill the kidney small, because eventually the kidney will go. But we always want the child to hit 10 kilograms. That is when we can transplant. And so we will kill your kidney small, because if you leave it, they will never grow. They are losing everything in their urine. Bartter syndrome and nephrotic syndrome. So we give indomethacin and ACE inhibition and medical nephrectomy that we are doing. So avoid those ones in your normal practice and avoid ACE inhibition. Especially when the person is not using diuretics. Remember, diuretics in combination will also cause hypovolemia, and then you can cause kidney injury if the person is dehydrated. And then monitor the BV creatinine. So discontinue the NSAID if you realize that. And this recovery is rapid. Okay. Once you see that this is either NSAID use or whatever, you discontinue it, the recovery is rapid. But let's take note of that. So the same thing about the ACE inhibition and the rest, I'll talk about it already. The risk factors are, of course, anybody with renal stenosis, volume depletion, heart failure. Heart failure because the heart was not pumping very well, so not very perfused. The person has got a kidney injury already, including diabetic nephropathy. So don't use them. I've explained this mechanism to you. And the diagram is also telling you this. So that's the efferent. And this one is for the ACE inhibitor treated. No. So this was ACE inhibitor. Once you reverse it, then the thing is resolved. I'll talk about this already. This we know, creatinine rise. So this diagram is just confirming the same thing as it is. So prevention, recognize those at high risk, initiate a low dose, then titrate it 2 to 3 weeks, and then avoid NSAID and diuretics in high risk or dehydrated patient and appropriate monitoring. And also discontinue the ACE inhibition. In fact, even in normal patients, when you give ACE inhibition, we are initiating them as antihypertensives. The creatinine will rise somehow because of some of these mechanisms. But it is supposed to recover probably by 3 months. If by 3 months, say then the recommendation is to stop it. Or the person hasn't got renal stenosis or something. So let's take note. And of course, they also cause hyperkalemia. So take note of this ACE inhibition. Nephrotoxic drugs. So we know that they are inherited nephrotoxic to the kidney and they cause acute tubular necrosis, not the hypersensitivity one. That one is the second one, B. And then precipitation. Let's look at that. What should I see? So these agents, aminoglycosides are there. I'm a time. I can say. Yeah, 10 minutes. Okay. So aminoglycoside we know, but we also know radio contrast when they give media, contrast media to CT scan and the rest, know that they also have risk. Cisplatin. A colleague daughter tell me the daughter is on this one. He said it's a terrible drug. Doesn't want to. Cisplatin. So the cancer people. And there's this fungal drug called amphotericin. Actually, Mignon, my professor would tell me, we always say that drug called amphotericin B is actually called amphoterrible. It's so terrible you're kidding. So you say I'll give that drug amphoterrible. Terrible. So if anybody is on this, let us take note of that. And the other osmotic agents. So they will cause that, and they will cause, if you are put on a process, you get oliguria. But the tubes shed and they block the lumen, so you get oliguria. It was the some of them I said aminoglycoside in particular, they don't cause that, but other this will cause. Let's take note. And you know the aminoglycoside, gentamicin, tobramycin, neomycin, amikacin. And the mechanism, they say that they are cation drug. And so they bind to negatively charged tubular epithelium and they damage the lysosome, cellular lysosome, this thing. And so the more catenoid or more positive that drug, the more toxic it is. And so among the four I've written, neomycin is the most toxic, but that's the most catenoid. That's why we don't give it systemically. No, neomycin is always a topical drug, but the most toxic drug, followed by tobramycin. And people say getting urethritis from gonorrhea. I say there. I haven't seen some for a long time. Are people say getting it or we don't know? Gonorrhea. When they were getting gonorrhea those times, I don't know whether they are still getting. Then they go for tobramycin. Okay, it's toxic. Gentamicin. Apparently, I did not even know that gentamicin is even more toxic than mecacin. No, they may be in the same group because I think they put the brackets here. And then streptomycin is the least because it's the less catenoid, this one. So like I've said, what's the recommendation? So they are taken out by the plasma tubule and then they cause necrosis. And typically they are non-oliguric. That's what I tell you. A person may see the passing urine, have a proteinuria. So if those drugs are given concurrently with other toxic drugs, then the chances of them causing the injury is more. So let us make sure that because the antibiotics sometimes that's the only line of survival. So let's make sure that we eliminate other drugs. But if you can actually do the levels, that is very key. If the person got a CKD before, then that's a problem. Prevention, the use of antibiotics if possible. Otherwise, limit the total amount of dose and the duration. Usually, I don't want people who can do a level. I say don't go beyond 7 days. I tell people like that. So don't go beyond 7 days. It's a bit worrying. And then, of course, you can do the level there interval, but sometimes you give it once daily and avoid volume depletion during those administration. So let the person receive a lot of fluid and avoid concurrent medication. But if you discontinue, it's reversible. This one is unexplained. And almost every drug is acute idiosyncratic reaction. Every drug can actually cause that. And the diagnosis is by kidney biopsy. When you see eosinophil, they are red when you see them in there. So they come with steroiduria, a passage in the urine that you cannot culture anything. So called steroiduria. That's endocarditis. And I say that even though they are, because it's a hypersensitivity, the person may have other systemic manifestations like fever, macular rash, eosinophilia, arthralgia, you know, those serum sickness kind of things. They can actually get that. So that is how it is like. And look at the drugs implicated. The cell wall seducing inhibitors. In fact, penicillins are also here, not only so beta-lactams, the penicillins, and including cephalosporins, NSAID, or therapeutic agents, plastin is the ARVs. Look at vancomycin, ciprofloxacin, omeprazole, and all the ulcer treatment drugs are there. Even loop diuretics, sulfonamides, they can all cause these things. Don't forget the NSAID. So a lot of drugs actually can cause that and cause this acute reaction. And the treatment is you stop this one, you give steroids. What happens is the reaction. That is how it is done. So beta lactam, that's what it is. And fever, rash, those things I've talked about it. Good. And the treatment, I think we give steroids. I didn't talk about the treatment. We give steroids, you stop it and then give steroids. Those are called crystals. So these things, some of them cause direct tubular intratubular obstruction and cause kidney stones, crystallization. And those ones commonly occur when in the setting also hypovolemia. So give a lot of fluid. Okay, if you give a lot of fluid, then that is fine. And some also cause indirect obstruction when large amounts of them are taken. And I talk about myoglobin and the hemoglobin. They are not drugs, but they also cause tubular obstruction. And when we are giving, when anybody comes that hemoglobinuria, that's why we treat it by increasing the fluid intake. You can even give diuretics if you want. So these drugs can actually crystallize. So take note of them. The cyclovir that we use to treat hepatitis, herpes, is cyclovir. This was HIV drug, but is no more in use. And sulfadiazine is also used for many other things. This one is part of septrin. So when you see, no, Tamsin is different, not part of septrin. Methotrexate, this is also HIV drug. Tenofovir, that we know that causes this one, and ciprofloxacin. They can all precipitate. And so when you give it, let's take note. We give a lot of cipro, isn't it? Let's make sure that so that chart, we say you're hemolyzing and then you're giving cipro, BCP. But your cipro is even causing this. Let's give a lot of fluid when you do this ones. Crystal, this things, of course, there's discrete because they block this thing. So the discrete unit are put the creatinine will be going up. And you can also get that. Prevention and management, hydration is the key thing, discontinuum, volume, resuscitation. Take home message. So be cautious with NSAID and ARBs in a setting of hypoperfusion. These are drugs we use a lot, so let us be careful. And for a patient with documented impaired renal function, please avoid the phototoxic drugs. At best, only first dose for antibiotics in the absence of dose levels. But otherwise, check for dose adjustment for all the drugs from BNF. Let's check. Why the person has got documented kidney function, dysfunction? Do that. And remember that painkillers are actually kidney killers, particularly if they are used in a prolonged manner. Okay, but of course, they can also cause acute kidney injury, the setting of hypovolemia. So this is what I wanted to tell you. There are many, many other things you can see about drugs and the kidney. But for me, the ACE inhibition and the hypovolemia are very key things I wanted to stress. So thank you. So okay, I've done, and I've got 5 minutes I've given to you. So let me take questions if you have.
So much. Okay, thank you so much, Prof. And then I think it's been a very elaborate lecture. Then for some of us, we are learning new things. So if there are questions online, and we stated earlier that you could put them in the chat box so that we would pick them up. But in-house as well, please. If there are any questions from the 2 lectures that have been given, and we can discuss them before we take the remarks from our chairman. Because we are almost rounding up. So please, any questions from in-house whilst we are monitoring those online as well. Okay, so there's a question online that we'll take whilst we are waiting for the in-house. Okay, Lutechi is asking, when combining ACE inhibitors with LASEs, we typically avoid spironolactone. Okay, so it's more like a contribution, not a question. That when combining ACE inhibitors with LASEs, we typically avoid spironolactone due to hyperkalemia in CCF, congestive cardiac failure. So
I would say that commonly, when we are, because ACE inhibition is the drug for chronic heart failure, and sometimes we also give heart failure, so diuretics. But when the person can be decompensated in the wet phase, and you are giving very high dose lysis, we don't give ACE inhibition. Don't give that. Okay, when it's out of it, in a stable dose that we are giving, the dose of the directives we are giving, then you add your ACE inhibition to it. But of course, remember, it can cause hyperkalemia. Then it can also cause this. But Chrissy, you must know that now there are 4 blocks. You must know better than me. 4 blocks in treating chronic heart failure. So, mineralocortical receptor blocker is there. Must give it adatone and the other newer ones. That one is beta blocker, the newer ones. So, bisoprolol and the rest, you also give that one. And then you give ACE inhibition. And then the 4th one is the SGLT2 inhibitors. These are the 4 pillars. They call it pillars in treating this thing. So, you may have to give, if for the chronic, not acute. But of course, the presence of adaptone and ACE inhibition, probably the lysis is helping somehow also to clear a bit of the potassium. But otherwise, you need to also be monitoring this. That is what I would say. Good.
All right, please, any questions? Let's drop out. Okay, let me ask mine. And I want to know, especially about the herbs. I mean, that didn't come out a lot in the presentation. Drugs and herbs. Yes. In fact, initially my mind was mostly about the herbs. Yes. Okay. But I mean, you know, currently we have the herbal medicine as a part of certain facilities that they also prescribe it. I mean, if you come and you want alternative medicine, they direct you there. I don't know whether you have any comment on. Because these ones, you would think that it's in the hospital setting, so may have been regulated.
Yeah. I must apologize. My mind was on drugs. Since we do in hospital, my main focus on doctors, not herbalists. It's a major problem. I mean, recently at the which meeting did we have in Accra? Was it PSG? It was PSG. I went to a malaria session. So one guy was sitting there. Actually, they are the promoters of the herbal medicine thing. He has been giving me a bottle. Was it nano? Nano juice. Baby, it's me table. I mean, what's the menu? I said, or say, oh, we are testing FDA. So it's my table. My wife says, what is this? This is herba. What herba about her? So he was promoting this thing that works. But I said that, you know, the way orthodox medicine, before it will come to the market, rigorous these things, they should do something like that. And they should also include the herbs in trial. The only thing can tell the things. That's when they dose, everything comes in. But the way you are giving the thing to me, and then, so as for me, they are not a friend of herbs. I must tell you, because I know kidney. Because look, I'm telling you, orthodox medicine that can affect the kidney. How much more herbs? So I never recommend herbs for anybody. Okay, I never recommend that because I know that even orthodox medicine can cause damage to the kidney. And the way they do the herbs, do they do powered chromatography to get the toxins out? Even though they may contain efficacious this thing, but the way they do it, don't they boil it? Do they ever do chromatography? You must know that in orthodox this when we talk about gnosia and the rest, yes, they are used herbs, but use chromatography tends to extract what you need, and you leave the toxins there. But there were herbs, they boil everything, isn't it? They say a actually, liver is not, it doesn't taste well for me at all. But people like the liver. It doesn't taste well now. I don't think so. But then they say that they be about because this one. So that's how it is. But they will use scientific medicine to extract what they need and leave the rest. That's how orthodox medicine comes to play. But the herbs, they boil everything together. And so I must say that this is orthodox. Herbs don't go there at all. I don't want to go there. So it's a dicey thing because they say FDA approved and the rest. I will tell you that in my normal roofing, that is approved. I also cause kidnapping. So the same way herbs. So I don't recommend herbs. If you like the not juices,
Thank you for that response, bro. Yes, so, and there will be another thing for our CPD points. So those online, don't leave yet because we need to input to show that you've really joined and learned from the CPD. Please, if there are no questions in-house and on, okay, there's a question.
My question is directed to Prof. I have 2 questions. If Dr. Nima is here, and actually both of you, this is, I know we are talking clinical, but in terms of public health issues, how do you bring the public into this conversation? This is Pediatric Society. We are talking about detecting, we are talking about preventing. So if any of you can comment on that. And from the second one is specifically for you. I think one point which I am particular about is patients we see at our emergency unit, infection, sepsis. We go in with antibiotics. We start with antibiotics. You've highlighted key antibiotics that can cause a problem. You've highlighted the issue of hemodynamic instability. It's a favorite area for me. I want you to comment on that since you are doing this presentation. Any guide for the doctors who manage in general, not only our residents, but also the general practitioners who are listening to us?
So a public health one, science, like Mami, the talk we give for the public and go there. You know, in children, Kakut causes is a significant contributor to chronic kidney disease in children, Kakut. So if you see it early, it's better. So we say keep on telling them signs to look for that indicates kidney failure. Early morning facial puffiness, failure to thrive is important. Of course, somebody whose leg, when we say they got a bow leg and the rest, if they've got a tubular problems, they tend to have that. And then if somebody has got any problem with the urine, either the flow or the color or the scent, these simple things, they should be able to get to a doctor. But you know, the problem with the early morning puffiness is that in the course of the day, it goes away because gravity driven. When they sleep, it goes there. So the mothers don't take them serious. But then we need to highlight that once we see a swelling. But I must say that, of course, it can also be allergic conjunctivitis. But even that, I say, come to hospital, let's see. But I think one of the conference I went, somebody was saying that a lot of people with renal disease, people miss them and they take them to be allergic conjunctivitis. Actually, it is renal disease. So for me, all I say is that look at the person's urine. Once you do urine dipstick, you can see. But of course, in the house, they wouldn't know that. But I also tell them that if they get an opportunity to do what we call medical examination at school entry, they should do it. And they should stop crossing you at church and they give you the form that my child is going to school. It's a form. Can you fail for me? They should go and do it. My daughter will go to secondary school, Wesley girls, and they will insist that you come make a medical report. So me, all of them will come and do the test. And when I came and Ati was giving it to me, I just collected it. I was just going to give it to the school. I know my daughter as well. I said, no, boss, the age being low. My daughter's age was 9. You know, these young children, they started menarche. And then they were just pouring blood through. Huh? 9. You're going to go to school with age of 9, so you not understand anything. They're teaching them anemia and we have, huh? So you had to go to school with a lot of iron at the school clinic. So every morning, go and swallow before you go to this. So you see, so I always do that. So let's tell the public. If they say go and do medical examination for whatever they say, go and do it. So if there's a problem, we'll pick it. And commonly they'll do stool and urine. And so if they see any problem, but I'll tell them that once the urine color, it becomes foamy, it becomes there's a scent in it, the color is not and the flow is not this thing, it may be it. The child is not growing very well, edema here, it may be it. The less this thing. So that is what I will tell them. That one is to detect the one who has got a kidney disease. Nevertheless, risk factors, like we know, salt root, skin things, they are very important things. Okay, like my colleague doctor who said that the child was getting recurrent this one, then because he's an ENT surgeon, he even went to remove it. Not knowing that he has developed this thing, maybe chronic glomerulonephritis, he had this one, okay? And so let's mention those things to them. That if anybody gets sore throat, you go to hospital, got a skin infection, you go to hospital. And that is those who are at risk. Then the things not to do to damage your kidney are also the herbs. A lot of mothers give a lot of herbs, including enema, to their children. And these things cause a lot of damage. So let's tell them that I don't think children take a lot of NSAID. It's usually the adults who take it for a very long period. Nevertheless, let us advise them about against these things that they can cause kidney damage. So for the children, that's what I would say. To detect the one who has got it, in terms of the urine growth, blah, 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 things like that. And the risk factors like sore throat and skin infection, because glomerulonephritis, one of the things that cause these things. And then they should avoid herbs, of course. There should not be a perpetual somebody who will be giving painkillers for a very long time. That's what I would say. Now, the person who comes to you, you got infection and got happy, but I think the normal thing that you need to do is stabilize the hemodynamic system, give fluid to make sure you stabilize it, whatever you can do to do that. And remember, the hemodynamic one, what I talked about was NSAID. So if probably in the meantime, paracetamol is not much of a problem. So it's a fever you want to control, fine. But there is the NSAID. Paracetamol, most people don't consider that as NSAID, but it's central acting. So that's the worry. And of course, ACE inhibition, but you may not be giving ACE inhibition, a critical A person. But I was just saying that for the, of course, if the person is unstable, I'm going to give a drug that is toxic. It is alternate, give it. But otherwise, if it's antibiotics, you think that is what you're going to do. So I'll probably give the first dose. And if the person becomes a bit stable, then probably you can continue this thing. But once you say unstable, if you give repeated dose, that becomes a problem. I think that give probably the first dose and do what we can to stabilize the person. Okay. Other risk factors that cause the precipitation. If you want to give those drugs, Cipro and the rest, the person needs CT scan. You know how to prevent this. Adequate hydration. If you do adequate hydration before the person go for this, of course. But here we are also giving N-acetylcysteine as a prophylactic medicine to guard the kidney. The person needs these things and got a problem. We have been giving that. But I think hydration, if you give the person hydration, good hydration, then you can avoid some of these things. So, John, that's what I will do. But otherwise, it's dicey. The person is very ill, need to give this one, and then the kidney is also then suffer, and then you are in there. So, if you can correct the hemodynamic instability and the other alternate drugs that are available, a bit friendly to the kidney, let's use those ones. But if by all this and what is left is this one, I will give a first dose. Just do all the things I can do. If it's stable, then I can do that. I said, that is it.
Thank you so much, Prof. So I think there are just a few comments on the Zoom. We'll take one or two of them. And so someone is asking whether persistent hypoglycemia in a unit can be a sign of kidney disorder.
No. Remember, persistent hypoglycemia, think about the adrenal cortex. Remember that cortisol are one of the major hormones of fasting. So when you are fasting, they all come in there, okay? And so anybody who gets any kind of hypoglycemia, make sure that he hasn't got hyperplasia of the islets. And I got Wedman, I can't say Beckwith Wedman or insulinoma. I know a very famous doctor here, which I won't mention the name, and was labeled to have epilepsy, and they were giving anti-epileptic drugs. And were not getting control. So he's getting attacked, come to the, do you know what he had? It was insulinoma. A doctor who is of my age, famous doctor, I won't mention the name. I don't know how come that somebody said, no, let's consider this. He went to do this on insulinoma. So they flew him to Germany, removed the thing, then the so-called epilepsy went away. Hypoglycemia. So let's consider this. But I'm saying if somebody gets in persistent hypoglycemia, it means that other the epinephrine, the cortisols are not there. If they are there, they're able to. Okay, and that is why we need to look at that. And newborns can actually have those problems. Another with Redman, therefore got hyperplasia here, insulinoma is there, and any of those things, or a narcotic failure. People are born with congenital adrenal, those who are born with all these defects along the line of the pituitary. Probably you hasn't got panpituitarism or hypopituitarism. All these conditions, the children can come with persistent hypoglycemia. So we consider the cortisol pathway if somebody is getting this thing, persistent hypoglycemia, but not kidney disease. The only condition that gives you hypoglycemia in the kidney disease is if the person is on insulin, because the kidney helps in insulin excretion and the rest. So if somebody's kidney is failing and you give insulin, then you need to reduce the dose of the insulin you give. You understand? So if you give a normal dose of insulin you are giving and the person got kidney failure, then we're getting episodes. Okay, children, there's insulin. We don't use oral hypoglycemic agents. So that's the only thing that hypoglycemia may be linked with kidney disease. Otherwise, please consider hyperplasia of the disc or the cortisol pathway. Newborn probably got hypopituitarism or pampituitarism. That's why it's getting that. And when you have gotten pampituitarism, so you know that the adrenal cortex is also affected.
Okay, all right. Thank you so much, Prof. So I think we've exhausted the questions. The others will be answered on the chats, in the chats. I think Dr. Marty is answering some already. Yes, so we are almost nearing the end of our presentation. We'd like to say a very big thank you to our presenters. But yes, of course, we started and then there was a chair. So we want to take the comments from our chairperson as we are finalizing the meeting.
Yeah, thank you very much for the presentation. I guess you, as participants, you all agree with me that we have been given a potpourri of renal information for the kidney. We started with a question, an important question, which was part of the theme, are your kidneys okay? And incidentally, if you followed the instructions given by the organizers, at the end of it, the same question is there, are your kidneys okay? Yes, I don't need to add more to it. In between, we've been provided a lot of information, how to detect and how to prevent. These are simple procedures, simple routines that we can do to protect the kidney. Dr. Mamianima made another interesting comment during her presentation that the most important organ to her is the kidneys. The rest are all supportive. Well, initially I said this is debatable, but at the end of the day, I'm shifting towards her. She's not convinced me, but I'm shifting towards her. Now, the rest of the organs must stand up and be counted in this contest. So, Pediatric Society, I'm challenging you to look for the rest of the organs and let them speak for themselves. We are here shifting ourselves. But eventually, I guess with Prof. Entry's final delivery of the advocacy work, I am also very interested in the public, because without the public, we cannot reverse the rising, we cannot reverse it. In our rooms alone, in our consulting rooms, on our wards, we cannot reverse the numbers going up. We need the public to be with us. I'll end on that note. Again, are your kidneys okay? Thank you very much.
Thank you so much. I think it's been a very wonderful session, and then it's great to be a part of this. We are at the end of our session, and those who joined online, we are so grateful. I think we had close to 150. Yes, joining online. So it was well publicized. So thank you all for joining, and then please register for your CPD points. The link has been posted again in the comment section. Once the meeting ends, the forms will not be accepting any further input. So I'm trying to do that whilst we are still on the call. So we are at the end. Prof, Mr. Which we are registered. So would want to invite our sister Esther Obeng, to give us a vote of thanks, and then the closing prayer. Yes, those who haven't paid their dues. All right, so we'll be ending shortly.
Thank you very much. So please, we've also shared the link to the membership form. Like if you want to be a member of Pediatric Society, we've shared the link in the chat box. Okay, so would like to thank everyone. We thank our presenters. We've really been educated today, and we are grateful to our presenters. We've learned a lot. We would also like to thank all participants, those here with us and those online. We are so grateful, and we would like you to continue to join our monthly meetings. Okay, so next month, we'll definitely have another meeting, Pediatric Society, and we want you to look out for our flyers, and then you join as well. Thank you very much. And closing prayer, please. Let's pray.
I'm happy that also, well, this is a kidney month. March is kidney month. We're all over the place. And I think my team have done very well of publicizing our kidneys okay, because that was the team for this year's World Kidney Day. And so for choosing to host nephrology for this, I think that is a big contribution. But all the things we have learned, let us just keep on going to share and pay attention to them in our practice also. So I'm very impressed about this also. Thank you very much.
Thank you very much, Prof. Please, shall we pray? Father, in the mighty name of Jesus, we thank you so much for our lives. We thank you for how far you have brought us. We pray. We thank you for this successful program. We pray that everything that we have learned here today, you will help us to remember at the time when we are required to put them into use, so that at the end, your name will be glorified. We thank you. We bless you. In Jesus' name, we've prayed with thanksgiving. Amen.
Amen. Yeah. So thank you very much. Just a little announcement from our Vice President, Pediatric Society. So on the 22nd of next month, April, we have the Earth Day and Anti-Galamsey webinar. Yeah. So on the 22nd of April. So please book it on your calendar. So just mark it on your calendar. And then if you're not on the PSG Ashanti page, kindly alert me after the meeting. Let me add you to the page now. Thank you very much.